Hello and welcome. I'm Steve Clements, contributing editor for The Hill. Thanks so much for joining us today for our forum on improving treatment and recovery for opioid use disorder across the criminal justice system. I'd like to thank our sponsor, Indivior, for their support of today's event. Opioid use is highly prevalent among incarcerated individuals, yet only a small percent of them receive medication-assisted treatment in jails and prisons. Studies have shown that treatment for opioid use disorder within correctional settings can reduce the risk of overdose and reincarceration. Today's conversations are going to explore the roadblocks that incarcerated individuals face in receiving effective support and treatment. And we're going to examine what it will take to ensure a safe and successful return to society and the role that recovery services and diversion programs play. Before we begin, a few housekeeping notes. You can tweet us at The Hill Events using the hashtag #TheHillOpioids. We're broadcasting live and we'll take your questions throughout the program. Congresswoman Madeline Dean of Pennsylvania sits on the Judiciary Committee and is a member of the Bipartisan Addiction and Mental Health Task Force. The Hill's editor-in-chief, Bob Cusack, my friend, spoke with her earlier this week. Take a listen.
Congresswoman Dean, thanks for joining us today. Really appreciate it.
Thank you for inviting me, Bob.
Well, opioids is a very personal issue to you, your son, and you've written about this. Has dealt with addiction. Can you tell us that personal story?
Certainly. And Bob, feel free to call me Matt or Madeline. And thanks for asking. My son and I wrote a book about our experience, his experience as he fell into addiction to opioids, my experience trying to figure out what was going so terribly wrong with him, but much more importantly, the story of him getting help. He slipped into addiction over the course of about 8 to 10 years, and was very good at hiding it, very good at manipulating what was going on. And you can imagine, as a mother, I was in a panic because I could tell from his affect and also his physical appearance that something was terribly wrong with him. So we battled for years. We finally figured it out and confronted him, and he said yes to help. So I have taken this personally for a very long time. Addiction is a disease. Substance use disorder is a disease. And so my entire public life, 6.5 years as a state representative and now 3.5 years in Congress, I've been working to destigmatize the issue. If I can tell my story and say it happened in our household, I almost don't know any household that doesn't have some connection to mental health issues, addiction issues. So thank you for asking. There is hope in recovery.
As far as people who are watching, because I imagine that was just an incredible struggle for you, what advice do you have for families? You have experience of going through this difficult process, and obviously it's not one size fits all, but what would you advise to parents and family members, to people who are addicted?
Well, I would say, number one, as parents, trust your gut. My gut told me it was drugs, but Harry was very, very clever at hiding it. I would drug test him and he would anticipate it and somewhat beat the test. So trust your gut, get professional help. I leaned on a friend who had been through it and is now a person in the recovery world helping others. So seek professional help. Don't think you're alone. Don't think you're crazy. And just keep reaching out to your family member who is addicted. Harry is now 9.5 years, a little more than 9.5 years in recovery from opioid use and addiction. He's now in that same space, helping others claim recovery through treatment and continued treatment. So I would just say, trust your gut, seek professional help, and recognize you are not alone. Don't walk in a shadow of fear or shame. This can happen to anyone. It is a disease. It is not a moral failure.
Big picture, you've been working on this for a long time. What have we been doing right, and what do we need to keep doing? Because this issue, honestly, I think has been with the pandemic, obviously has not helped the situation, but people are not maybe talking about it as much as they were before the pandemic. So where do you think that we've succeeded, and where do you think we need to pass them? And obviously, I know you've introduced a lot of legislation on this issue.
Well, I will say we've succeeded in talking about it more. I think that is powerful and important. And families who talk to me who've been through this, maybe lost a loved one, they're thankful that we are talking about it. We're trying to pull back the curtain of shame and stigma, but we have a long way to go. I absolutely know that. I think we've been somewhat successful in prevention, but I think we have a very far way to go with that. When I think of how we educate our young people, we have to be really honest with them. My son tells the story around going through the DARE program when he was young and realizing, oh my goodness, he pledged to himself, never, never, never. Maybe we have to relook at the DARE program, because what the DARE program, it does some very powerfully good things, but it also just says drugs are bad and then connects the person to bad. So we have to speak about it differently and with compassion and greater understanding. I know you know this, but we are talking about now during the pandemic, 110,000 people have died of overdose in a 12-month period that ended April of last year. 110,000 people. That is 300 people every single day in this country. Monday, Tuesday, Wednesday, 365 people, 365 days in the year. I call it a jetliner a day, Bob. In this country, what we've got to do is figure out how we land this plane. When Boeing had 2 jetliners go down within weeks of each other, claiming souls, they said, land the plane until we figure out what we can do. We need in this country to do everything we can to put resources toward prevention, treatment, destigmatization, decriminalization. There's so much there. Something good we did that I think is little noticed is the American Rescue Plan, where we put $3 billion we distributed to states and territories in order to combat addiction and to help people get into recovery. That's a powerful set of resources. And there's so much more in the American Rescue Plan around the issue of addiction. I'm mighty proud of this administration, President Biden. He and I have talked about it in terms of what we're going to do for those who are suffering from the disease of addiction.
You've introduced legislation on incarcerated individuals, and that's not something that we talk about maybe enough. What is the issue as far as addiction in prisons and jails that really needs to be fixed? This is something that we talk about 300 people dying a day, but very few people are thinking anything about people who are incarcerated. And some would say, well, why should we focus on them? Why should we spend money on them?
Because they're human beings. We should absolutely spend money on people who are incarcerated. Number one, most of them will re-enter society. So do you want them to re-enter society having been invested in so that they will succeed? Or do you want to not invest in them and they will come out and too often fall back into substance use disorder and using, too oftentimes to die, or recidivism, being rearrested, brought back to prison. People who are suffering with addiction, it is a disease. Sadly, you might imagine, I sit on judiciary, and there was a sad set of arguments being made back and forth on some of the legislation around incarcerated people and treatment. People need treatment while they are incarcerated, and then connection to treatment and recovery as they leave. And I heard a member on the other side of the dais arguing, just arrest them, throw them in jail, that'll stop it. Well, of course, that shows a woeful ignorance around the disease of addiction. So some legislation that I have introduced, one is for educating people, training people as they are incarcerated, the PrEP Act. I had the chance of introducing that alongside Elijah Cummings in 2019. So that's for education, training, to make sure that people have some ability to find suitable employment so that they will not hopefully go back to the streets and maneuver toward crime, drug use, drug sales, and other things. The other thing we have to look at is who's incarcerated. We were talking about my son. You can imagine my son is a white kid. And when he was young, he looked pretty darn young, and he drove a decent car, and he had a suburban address. He talks a lot about being treated unfairly fair. He'd be pulled over. It would be obvious he had had a problem or had been using, and the police officer would take one look at his license and say, kid, get home. That doesn't happen for everybody. That doesn't happen for those who are impoverished. That doesn't happen for those people of color. We know that way too often, Black and brown people, poor people, are arrested for their drug use, not offered treatment. So there's so much we can do to figure out how we don't send so many people to prison for a disease, and how, when they are in prison, we get them treatment so that when they re-enter society, they have a chance to continue recovery.
As we live in such polarizing times nowadays, but obviously opioid kills Democrats, Republicans, and independents. Has this been an issue that you've seen a lot of bipartisanship on? I mean, just in general, in dealing with opioids, because obviously it affects every district and every state in the nation.
I do see bipartisanship on this one. I don't see a greatest sense of urgency, as I said, with that horrific number, 110,000 dead in 12 months. But there is serious bipartisanship, and it gives me hope. I think you're going to be interviewing David Joyce. He has a lot. He has a lot of proposed legislation. He cares deeply about this issue. We have an addiction caucus. It is very bipartisan, bicameral. So yes, this is a place where we can agree, because you're absolutely right. Overdose deaths are stealing people of every color, creed, educational status, economic status. I sadly was recently at the funeral of a friend of ours, 24-year-old white, young man, struggled with addiction and sadly died. And you know what his parents said as I came up to see them in the church? They hugged me and said, "Please, we must do more about it. Please pass legislation that will help with prevention, will offer people greater recovery, harm reduction, and of course, treatment if they happen to be incarcerated."
And that leads to my last question. It's a midterm election, everybody's charged up and looking towards November. I know a number of bills have passed the House and haven't gotten the votes in the Senate. Are you hopeful that some piece or pieces of legislation could pass sometime this year? Maybe it's after the election, maybe it's a lame duck, but could be attached to some moving vehicle?
I certainly hope so. We passed out of the House the Fairness in Orphan Drug Exclusivity Act that would close the loophole that prevents us from getting some of the most innovative treatments for substance use disorder, medication assisted treatments. That's passed the House. It's in the Senate. Things like that, I think we should be able to get bipartisan support. And of course, making sure that whatever we do has a holistic approach. I really want us to do more in the area of harm reduction. I don't know, Bob, if you've ever visited an area of Philadelphia, Kensington. Have you had a chance to be there?
I've been in Philly, but not Kensington, I don't think.
I ask you to go. I ask members of Congress to go. It is a hellscape of poverty and substance use disorder ravaging souls. And so there are very good groups there trying to help people, trying to get them into recovery. But it was there that the city was going to put up a safe injection site, but that became very controversial, and so they didn't do it. We have to think outside the box. It is not inappropriate to protect people while they are struggling with addiction, to save their lives, naloxone, safe injection sites. But, we have so much more to do. So I do hope that in this Congress, there's an awful lot going on, so many extraordinarily pressing issues. We have important elections in my state of Pennsylvania. I hope we will make sure we do something to reduce the loss of life and get more people into recovery and reduce addiction. I've literally talked to President Biden about it. He takes it personally too. So I'm pleased with what he's trying to do by way of executive order. And I know he hopes some of this legislation gets to his desk.
Well, Congresswoman Dean Ormad, thank you for joining. You have a compelling story, especially with your son. And it's such an important issue. And we all appreciate the work you do on this.
Thank you for your important coverage. Thanks, Bob.
Thanks.
Thank you again to Congressman Dean and Bob Cusack. Joining me now is Congressman Dave Joyce from Ohio, a state that's been hit particularly hard by the opioid epidemic. He's the vice chair of the Congressional Addiction Treatment and Recovery Caucus. Congressman, it's great to see you again. Look, I always like to start these discussions when we're discussing opioids, treatments, and what we do to kind of become a better, healthier society with real people. And I just love our audience to know why this issue is one that you've taken such an important leadership stake in Congress, what it means to you, like what got you into this important track?
Well, before I got here, I was a prosecutor for 25 years. And during my time as a prosecutor, obviously you'd see drugs come and go, but there's not one drug that's had a worse effect on the American people than the opioids and then introduction of fentanyl and all these other things into the addiction system. And I watched people, unfortunately, addicted, watched people dying, and watched how it permeated society. It showed no lines between race, color, gender. It just didn't matter. And unfortunately, it was something that I was shocked at. And when I left and I got here, I wanted to use my influence, if you will, from my time as law enforcement to sort of put together and help craft a package that would deliver results. Because the unfortunate part is it's just devastated some communities throughout Ohio.
Well, it's something I hear a lot about from legislators. What I don't have a sense of is both in Congress and in the Biden administration, I suppose, what is the DEFCON level among your colleagues? Do they understand how serious this is? And do they have a sense that, the policy proposals you and your colleagues in the caucus are putting forward really need action now?
Well, that's a great question. I don't think we've acted quick or fast enough. Unfortunately, we're starting to make some great progress, and we continue to bring down the curve. But in 2018, we were at the point where we had our first decline in drug overdose in nearly 30 years. Unfortunately, we've had a pandemic. The pandemic completely wiped out, and I think it's exacerbated that the issue since then because people were left alone and people didn't have the ability to go out and do the things that are necessary, so they fall back to their old ways. And we also noticed that with whether you want to call it through the mail or through the border, fentanyl is involved more and more in the system, and it's being pressed into pills, it's being mixed in with heroin, it's becoming more in play in the deaths that are occurring, and it's involved in more American young deaths, especially the drug deaths, than any of the ones before, heroin, meth, cocaine, and prescription drugs combined. In fact, the CDC, fentanyl is involved in more deaths of Americans under 50 than any other cause of death. So it's imperative that Congress acts quickly to protect Americans from the surge of fentanyl that's been pouring into our country, provide support and care for those people who are struggling with addictions.
And that's just the general population at large, honestly. What we're talking about in addition today is looking at those people for a lot of reasons. It could be desperation. We have gone through 2 years of COVID. There's a lot of bleakness out there. And some folks end up wrestling with the criminal justice system, find themselves within it. And I guess, I've talked to people on the Eastern Shore of Maryland where I sometimes reside, and we have detention facilities there, and talking to people in law enforcement about the lack of connectivity they feel they sometimes have with patient care needs, opioid use and treatment and the various dimensions. I just be interested in whether or not you think we need to do more by way of just a platform of support for treating fentanyl and opioid abuse and use disorder in these prisons and whatnot, and in our justice system.
I think it's imperative that we do that because unfortunately, we found long ago that we abandoned mental health treatment programs and made the jail or the prison system the home for people with mental health issues. So now you take that and you compound it with people who are having drug addiction issues, and a lot of times also part and parcel of a component of mental health issues. So now you've got jailers trying to provide services that are beyond the extent of just housing somebody or incarcerating them or trying to reform them. And if I understand what we were trying to do with incarceration, yes, there's some retribution in having a person incarcerated. We were also supposed to rehab them and then reintroduce them to society. And so the costs that are going on in these jail settings is unfortunately being borne by local counties or state officials. So it's time we started to take some of the resources that we had available and make them available to those jails and allow people to continue, and as you brought up, the connectivity of their services with the actual medicines or the Medicaid or Medicare to make sure that they have the ability to be provided to them while they're in the system. Because I think it's very important that we continue to provide services and help treat these folks, because eventually they're going to get out. And you know what happens is, unlike alcohol or other drugs that have 28 days, it was over, then we have to be in a position where we provide some service and help for these folks so they don't go right back into the situation that drove them into the addiction, or the folks that helped drive them into the addiction. So, whether it's providing community-based education programs and then providing jobs for these folks when they get out. It's one of the reasons I introduced the Drug-Free Communities program, to give it the flexibility it needs to continue life-saving work among the pandemic, to try to help communities and in prison systems all work together so that they realize that this isn't the 28-day program. And it could be 9 months, it could be 2 years. And so we have to all work together and use every arrow in our quiver to try to do that.
Congress, I know this is unfair. I want to get all the answers from you, but I was really surprised when I did research for today's conversations on the level of incidence inside prisons, and it's high. I mean, somehow the availability, the incidence. What's not as available are the therapies for use and overdose. Now, I think that in schools, we've seen some of the controversies about schools because of young kids, in fact, finding overdosing and having various ways to respond to that, in certain states and communities. What is it going to take to destigmatize the therapies we need, so that whether you're sitting in the justice system, or you're sitting outside the justice system, or you're sitting in a community and you're alone and have issues you're dealing with, that we understand that this is important to help people? It's just sort of a missing part of empathy, I'm thinking, and I want you to fix it for me.
That's a great point you bring up. I participated in a program a few years back about stopping or breaking the stigmatization that goes around opioid addiction, and realize it can happen to anybody in any community. It's not localized to any one area. But secondly, it's similar to what I always say about the mental health area. If you have a broken leg, you get it fixed. You don't continue to do this problem or have the same problem. And we need to destigmatize both the mental health and the drug addiction issues, and start to realize that they were good citizens, they were good people, but for the addiction. And you could realize that when you see these folks. I want to give you a quick example, if you don't mind. It was when I did my time as prosecutor. I'm walking down the street and I see this lady coming towards me. I knew her son just got shipped that afternoon. I figured, well, this is going to be ugly, but it's part of my job. And the lady came up to me and said, "Thank you." Thank you. She said, our son went to a nice university, came home at first year. They were on a family trip in Europe. All of a sudden, the kids started what we would call jonesing, showing signs of the addiction. And they realized that, and he finally admitted that he had an issue and he had tried it. And then he had overdosed a number of times. And I said, "Well, look, ma'am, I don't see your son's name on a lot of these folks. Would be, from breaking and enterings. They'll be on pawn shops lists for pawning things or trying to get the money." She said, "Oh, no. By a week, he was doing fine. He was an apprentice for an electrician." The trouble was that on Friday, he'd go right back and buy what the amounts like he was from the person that he was buying it from, who, was no scientist, obviously, and they would get and take the same amount, but this time it happened to be a lot more fentanyl in it. And she said, "I know when my son's in prison, he's alive. I know that you're at least keeping him alive." Well, that broke my heart. I mean, that's you realize that these are really good families and really good people all over our country that are having the same problem, and they just can't stop it. And because the people purveying it don't give a damn about the person. They're now, as I understand it, pressing pills, make it look like fentanyl. Any way they can distribute their drugs, they don't care. So we have to start. I know people laughed about the old "just say no" thing that Mrs. Reagan had talked about, but started telling kids, like, you don't know what you're taking unless you received it from a physician, a prescription that you took to the drugstore, and you take it. Anything else that comes in a pill form could be deadly. And I think it's important that we continue to drive home that message and allow people to understand that there's no such thing as a safe drug from anybody other than a pharmacy.
Congressman, just finally, if you were to ask the Biden administration to make one big move in this area that they haven't made yet, what would that be?
To get serious about it. I mean, obviously, look, what's happening at our border is atrocious. Let me tell you why. My subcommittee on appropriations is Interior. We have 40% of the border, the southern border. When I went down there and you start to meet with those agents who are talking about it, they were talking about the amount of money that these people are getting to coyotes who are bringing the people over. And, we all know what else takes place. Obviously, this is where you have child sexual trafficking and other things. But they were saying they're getting like $4,000 per person to bring over the border. Now, if you're running drugs and you're doing this, the combination of these two, they're doing nothing to stop the problem. And the problem keeps getting worse. And so eventually you have to say, do I really want to, this is a war on our own children. Do we really want to take the war to them, or are we going to continue to pretend it doesn't exist? And I'm sorry, but there's no other way to look at it. Right. If somebody was sticking poison into our water supplies, wouldn't we do something about it? If somebody was trying to blow up, our situations in the high schools by, giving these drugs out in high schools, which is happening, wouldn't the local people be doing that? Well, why can't we do something nationally about it on a bigger way and fight this as though for exactly what it is, a war on the people in our country?
Well, Representative Dave Joyce, who is the co-chair of the Addiction Treatment and Recovery Caucus and doing so much in this track, really appreciate your time and your thoughts and your stories of why you're doing this. Thanks so much for joining us today.
Thank you all for what you're doing and for bringing shedding some light on the subject.
Now I'd like to introduce a message from our sponsor, Indivior. Please welcome Mark Crossley, Indivior's Chief Executive Officer. Take it away, Mark.
I'm grateful to be taking part in this important conversation during Mental Health Awareness Month and following the first ever National Fentanyl Awareness Day observance on May 10th. The opportunity for stakeholders to come together to make a difference has never been more urgent. We're in the midst of a growing and unprecedented fentanyl overdose crisis. The drug epidemic has claimed more than 100,000 lives in the most recent 12-month period, with over 3/4 of these deaths resulting from illicit opioids like fentanyl. The numbers underscore the troubling reality that an estimated 3 million people in the United States live with opioid use disorder every day. To address this challenge, we must treat patients where and when they are ready to enter treatment, including the criminal justice system. Many patients speak to the moment that they're ready to seriously enter treatment towards recovery. This moment could range from negatively impacting a family member to being incarcerated and losing all semblance of their lives. The numbers demonstrate that the criminal justice system is a key moment to address treatment, as due to the nature of this disease, 60 to 65% of patients come in contact with the criminal justice system at some point in their journey. Additionally, decades of science show that providing comprehensive substance use disorder treatment to justice-involved individuals works. According to reports, between 17 and 19% of individuals in jail or state prisons report regular use of opioids, yet only 5% of people receive medication to treat opioid use disorder. For those returning to their communities, they're between 10 and 40 times more likely to die of an opioid overdose than the general population, especially within the first few weeks. And while awareness is growing, and we're seeing advances in federal and state policy driving the implementation of evidence-based treatment programs within states, this disease is still too often viewed as a moral and a criminal issue rather than a chronic brain disease. However, policy and statistics, they don't tell the story of these individual people suffering from opioid use disorder. Our brothers, our sisters, parents, grandparents, friends, and community members. To help continue to bridge this gap in understanding, we're very fortunate to hear from Kyle about his journey with opioid use disorder and entering recovery. Thankfully, after 8 years of abuse, Kyle partnered with a healthcare provider with the right therapy regimen that included counseling and medications for opioid use disorder treatment. As a result, he recently celebrated his 3rd year in recovery from opioid use disorder. Before we turn to Kyle, I'd like to thank Congressman Joyce, Congresswoman Dean, and this distinguished panel whose leadership continues to make a meaningful difference in changing outcomes for patients, including those involved in the criminal justice system. Now let me transition to Kyle as he shares his story. Thank you.
My name's Kyle Salzberg. I'm recovering from opiate use disorder. I grew up in Lee Summit, small town, small neighborhood, tight-knit family, normal childhood. We were very typical, very American Midwest family. Worked at a bank all through college. As soon as I graduated, I moved back to Kansas City and started working at a bank 2 days after graduation. I had a career, lived in a condo downtown with one of my best friends at the time. Looking back, that was probably a couple of the best years I can remember. In the winter of 2008, I was in a car accident coming home from work. Hit from just rear-ended on the highway, had some whiplash and some stiffness in my back. Doctor prescribed me 10 milligram pain pills, said to take 1 to 2 every 4 hours as needed. I quickly learned that I could take 2 to 3 in that 4-hour window and felt great. So yeah, when I got that bottle, it was pretty much over. I went from snorting to shooting and was using needles daily. After only probably a few months into using. From there, it was just a downward spiral. About 2016, I was admitted to the hospital. I had a staph infection from using. Being ignorant like I was, I had asked my dad to bring a backpack from the house, but not to look inside of it. And I remember being wheeled back into the room from a test. And he was just kind of standing there holding up the drugs that were in the backpack. And that was a struggle. I mean, just laying there, knowing there's nothing I can do about it, and I've just crushed my parents. It was pretty hard. I went through treatment. It didn't quite stick. About 2 years later, I was admitted to the hospital again. I had an infection in my thigh that needed immediate surgery, had an infection in my heart valve that was endocarditis. So I spent 72 days in a hospital. Over that course, I mean, I had no friends come visit me, nobody even asked where I was. My family would come up there and see me, and that was it. So I lost pretty much everything. I didn't have any friends at that point. I had no job, no money. It was like, man, I gotta make some changes. I got to do something. So that was the real turning point for me. When I was released, I was not released with any treatment plan in place. So that's when I returned to the doctor I had been seeing just prior to this relapse. And I was able to find a medication-assisted treatment plan that worked for me. And with that, I did include counseling sessions with the doctor's office. And then I also attended Narcotics Anonymous meetings every day, and I did that every day for 13 months. I was also dealing with some legal issues at the time. I had accumulated some possession charges over the course of my addiction, so that was something I had to deal with in my recovery. I had no source of income, so my dad helped me, took me down to the jail. We turned myself in. I had gotten the possession charges. I had failed to appear. I would eventually got picked up, put in jail, or been put on supervised probation, which again, without any resources from my dad or my parents, I wouldn't have been able to pay any of my court costs, which would have been a violation, and I'd be thrown in jail and back into this cycle. It's a vicious cycle, whether you're in jail or out of jail. There is no clear course to recovery. They don't help you. They don't tell you what your resources are. It's just, you're kind of left on your own. Without my dad paying for and helping me out of the legal trouble I was in, I would likely still be wrapped up in this vicious cycle. The only way at the time I could pay it back to him was to try and earn his trust back and to stay sober and stay clean. And now that's one of the things that I'm proud of, is I've been able to stay clean and haven't touched an illegal drug in over 3 years. To be in recovery and clean and sober with good, solid friends again is very rewarding. I've restarted my career in finance. I now work as a cost analyst at a big financial company. I am, just living in the moment, enjoying life, but still definitely looking forward to all that lies ahead. There is such a stigma around OUD that people just don't understand it's a disease. These people want help, they just don't know where to get it. I tell my story to Americans suffering with OUD so that they know there is other options out there, help available, and a path forward to recovery.
What a powerful story. Thank you to Mark Crossley, Chief Executive Officer of Indivior. It's great to do this with you. What important conversations. Joining me now is Sheriff Stacy Kincaid of Fairfax County, Virginia. Within recent years, Fairfax County has introduced treatment and diversion programs across their adult detention centers in response to the opioid epidemic. I'm looking forward to hearing more. Sheriff Kincaid, I'm so excited to talk to you because I just want to be honest. You're very special, and the things that you're bringing into this conversation that you're trying to do to respect people that you're dealing with within the prison system or people that are coming in for a first encounter. You're doing things that I don't see happening much elsewhere in the country that I hope does take root. But why don't you share with us the unique dimensions that you, as the first female sheriff of Fairfax County in, I guess, 279 years, are doing it a little bit different than your predecessors have?
So good afternoon, and thank you for having me on your program. We do things very different in Fairfax County, and what we're doing to combat the opioid use disorder, as well as all addictions, is we've got a program that we've implemented called our STAR program, Striving to Achieve Recovery. This program is it's intensive, it's highly, it's authentic, and it's designed for individuals who have been chronic abusers of drugs and alcohol. And what we do in this program is we work with individuals. It is a program that's led by certified peer recovery specialists. And also we have support from the behavioral health and medical professionals. And this program allows the participants to hold each other accountable as well as hold themselves accountable. So it's a different way of approaching addiction. And we recognize that, you have to talk the talk to be able to walk the walk, so to speak. So by allowing this to be something that's very authentic, something that has never been done before, what we have found is that this program works, and we're very happy with the results that we're seeing.
I want to ask you about another program in a moment, but first, I'm trying to get my head around how most prison systems in the country work, because if you're honest and you kind of scratch beneath the surface, there is opioid availability in prisons, and there's use in prisons, and there is a treatment challenge. And if you're honest and look at a lot of these prisoners or those in the justice system don't receive the support. I'm trying to figure out, are they not receiving support because the sensitivity is not there, the resources aren't there, or is it because these prisoners are looked down on, there's a stigma, and so that the health system is actually not trying to accommodate, which is another form of impunity in my view. But I'm just interested in what that picture is.
So I can't speak a whole lot on prisons because I operate a jail, which is a temporary holding facility. We can have individuals locked up for hours to maybe 1 year or 2 years. It depends on when they are sentenced. And if they're sentenced to state time, they go down to the Department of Corrections. What I can tell you in jails specifically is that maybe there's some thought that individuals are not going to be incarcerated long enough in order for them to implement a program that's designed to help. And you brought up a good point about punitive. When someone comes into jail in Virginia, they are already enrolled in Medicaid. They lose those Medicaid their Medicaid is actually suspended while they are incarcerated. So as you mentioned, punitive. The other thing about punitive is that when a jail or when a prison does not treat the symptoms of one during withdrawals, what they're doing is when they only treat the symptoms, of those with withdrawals, this is cruel and unusual as far as I'm concerned, because what they should be doing is providing some type of medication-assisted treatment in order to make this humane. So.
That's a powerful statement you just made. I really appreciate it, your candor. You have another program that I've been reading about and doing research in, which I also find, Mark Crossley from Indivior just mentioned this being Mental Health Awareness Month. And given that, and you're on the front line of this, and I sort of think we ought to have Mental Health Awareness Year, with all due respect, keep this on our radar all the time. But I guess the question I have is, you have something called Diversion First. Can you share with us what that means? And so that folks that may not have, the normal contact with our justice system, what are the choices you, as a keeper of law and peace and providing security, what are the choices you have when somebody comes into your system?
Right. So Diversion First began in the sheriff's office before it was implemented. That is a program that's designed to offer alternatives to incarceration for individuals who come in contact with the criminal justice system. For individuals that are considered to be low-risk offenders, they're given the opportunity to be assessed and evaluated at our Marifield Crisis Response Center to see if there's an opportunity to turn them back over to their family, to get them into a psychiatric hospital, to get them back on medication. And if none of those are available, then they come into the adult detention center, and we have an opportunity for a post-diversion. And that's done through the work with our courts, our partners, our judges, my staff, certainly the defense attorneys and the Commonwealth attorney. And if there's an opportunity to put them on a supervisory release program, that's what we do. So we give them an opportunity to not be in jail. And frankly, what we do find is these low-level offenses, people that are trespassing or people that are actually sitting on a watermelon at a grocery store, these individuals don't belong in jail. They need help. And because we continue to be the default for the medical system, the behavioral health system, this is what it becomes our job. It becomes part of our job. And and we do this because it's the right thing to do to ensure that we get people the help that they need and the treatment they need. So then when they go back into the communities, that they have a better chance to succeed.
Sheriff Kincaid, I'm going to ask you a personal question, because you initiated this Striving to Achieve Recovery program, the STAR program, and it's unusual, and I think it's very humane from what I know you're trying to do. But I just am interested in what got you there. Was there a personal experience? Was there something in your profile, your friends, your experiences that helped you innovate in a system that often isn't innovative?
So thank you for that question. When I was a young deputy sheriff back in the 80s, and I had the opportunity to work in the housing units in the areas where individuals would come in that were withdrawing from drugs, mostly heroin. We see people at their very worst every single day, but to see somebody going through withdrawals and only treating the symptoms like with Tylenol or some other, vomiting, nausea, diarrhea. To see somebody go through withdrawals is probably one of the most inhumane things I have ever seen before. It's traumatic. And of course, when a female would come into our custody and she was pregnant, then of course she would get put on methadone in order to protect her unborn baby. But that really throughout the years, and you meet people throughout all walks of life, which I have, and just to see people that I know that we could deserve, they do deserve better. That's just the right thing to do. And we're talking about human capital, and why wouldn't we want to do the right thing?
So tell us a little bit about folks that exit the system, and we just saw this powerful, it was actually the sponsored content with Divya, but this powerful story of this young man. And the picture is that around this young man, for him to get on a different course, it took an ecosystem, it took family, it took a lot of other pieces, it took medical care. And I'm just wondering if we're giving enough attention to that dimension as people, because I've heard stories where parents want their child to go to prison and child because they believe that will help save their life. And it just sort of asks the question, what are we getting wrong outside that prison that we need to get right to help people become functioning, constructive parts of society, and to get, I don't know, beyond, like I was just discussing with a congressman, get beyond the stigma that keeps all that from happening.
Right. So you bring up several good points, and a lot has to do with breaking down the stigma. And even when it came to what are we going to name this program, this recovery program, I allowed the participants to choose the name because this was their program, not my program. And they did have something about stigma and about addicts in the STAR. In I don't remember if it was, addicts trying to achieve recovery, but taking the stigma out of it. And let's talk about recovery. And for the families that are at just, the tough love, we're done, you need to go somewhere because you need to be punished. You need to, I think it comes down to there are no resources. I also believe that you have to have the right people involved when you are treating individuals that are incarcerated, even when they're not incarcerated. But in our jail, their drugs and alcohol are not available. So historically, we would release individuals that were recovering addicts. And now we're actually releasing individuals who are in recovery. The individual who, what a powerful story that the gentleman had about, there not being any resources. And I can tell you that I've gone into the housing unit several times. It's not like nothing you've actually seen before, where there's honesty, there's respect. There is the understanding that if I want to be able to succeed when I go back out into my community, I've got work to do. But I think the biggest thing is to, we already know that, there's a problem, there's an issue. So instead of doing all these studies and, no offense to researchers, it's time to do something about it because we know that we can. But it's getting everybody on the same page. And, again, with the resources, with treatment, with funding. That's also a big thing. Not everybody has all these resources to make things happen. But I do believe that there is so much opportunity. And we have been very fortunate that having a program that we consider to be, or should be part of a national model, we've got other jurisdictions that are reaching out to us. And it's not about reinventing the wheel. It's about putting in place or sharing information that you have. And again, we realize that one size does not fit all, but take what you want from our program and do what you can with it. But the key thing is, not only having these, the right people available, but also bringing back the families, because families are huge. And with our program, we did bring back the family component, and to be able to see the parents and the interaction that they have, or the spouses or the loved ones. There's just nothing like it to just get back in. And, again, there's a lot of work that has to be done. There's a lot of anger, there's a lot of trauma, there's a lot of hurt, but the goal is to, try our very best and working with folks to get them back to a healthier and safer mindset, as well as physical, mental well-being, to go back into our communities, which again, make them safer and healthier.
Well, I just want to thank you. I look at these shows as really important opportunities for show and tell. So thank you for joining Show and Tell. Hopefully others will be inspired by the example of what you have done. Sheriff Stacy Kincaid of Fairfax County, Virginia, you're great. Thank you so much for joining us today.
Thank you so much.
What are state and local officials doing to improve access to treatment across the criminal justice system, and what is still needed to ensure a safe and successful return to society, which we were just discussing? Joining me now to go into this are Dr. Ross McDonald, Chief Medical Officer for the Division of Corrections of New York City Health and Hospitals. He's got a big operation. Dr. Kimberly Sue, Medical Director of the National Harm Reduction Coalition, a national advocacy organization promoting the health and dignity of those impacted by drug use. She's also core faculty in the Yale program in addiction medicine. And Dr. Justin Burke, Medical Director for the Rhode Island Department of Corrections, and Tracy Gardner, Senior Vice President of Policy Advocacy at Legal Action Center. She previously served as the Assistant Secretary of Health for the New York State. Thank you all for joining us. Let's just have a roundtable, discussion about all of this. Feel free to jump in, but I want to start with Dr. Sue. I want to read you something that I really like that you apparently said, or it's in my notes here. Maybe somebody else said it, but you said harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. And I just don't hear, it's what I was just discussing with Sheriff Kincaid, who I think gets it, but I don't think most of the system gets it. I just would love to kind of, take this organically from where your, efforts and movement are, and how much of a lift do you see and experience? You can discuss with our other colleagues here in this panel, but nationally, how much of the system gets where you're at and is trying to achieve that?
Thank you so much for the question, and I'm delighted to be here today to talk about these issues. I think the question of how much the rest of the country gets it is debatable. I think that for the first time, President Joe Biden said harm reduction in the State of the Union. But we still have a system in this country that is largely violent and stigmatizing to people who use drugs. And so that is why we always talk about the practical strategies that we can do as doctors and as clinicians and people advocating for policies. But we talk about it as a social movement, which was started by people who use drugs and letting them lead and working with them in a human rights-based approach. So you often hear in the US, we don't really talk enough about a human rights-based approach, but really people deserve dignity, compassion, and respect, regardless of if they're using or not, and wherever they are. So that is the grounding principle of all the work I think many people on this panel.
With what the sheriff just said, if I may, she used the words. I was asking, is there, when you deny or you're not providing that kind of support with people that are in jails and prisons, is that another form of impunity in that? And she used the words cruel and unusual, in her statement, which was a surprise that she went there, but she did say that. And so it raises this interesting question about rights and whether some of this is actionable, on behalf of those in the justice system. Dr. Sue.
Right. And I think Tracy is really well positioned to talk about this as well. Not only, the lawsuits that are coming to prisons and jails for providing this life-saving medication that we use, like methadone and buprenorphine. And, Ross and Justin also implement these critical programs, right? But even nursing homes, right? For example, we're having to file lawsuits against nursing homes because our patients in the hospital with endocarditis are being stigmatized and they have nowhere to go. So they just say, oh, we can't give them buprenorphine or methadone. And it's simply because of their treatment.
And Tracy Gardner,
in on that?
Yeah. Tracy Gardner would love, because I know you are actually, I love your tweets. You have one here: Black, brown, and indigenous people are disproportionately punished for using drugs instead of being referred to treatment. You refer people to a new report, but I know you're helping to navigate this. How big a problem is it out there that needs to be addressed?
Well, again, thank you for this opportunity to talk about these issues. And I think that the problem is deeply ingrained, and want to remind some of your viewers, this is not our first opioid epidemic.
Right.
We had one in the 70s, and we responded to that with criminalization and putting people in prison and jail. And that's about when Legal Action Center got started to say corrections is not the environment to treat people with this health issue. And I would contend it still isn't, although Dr. McDonald runs one of the first jails that provides medications for people who use drugs or people who have problematic drug use. And they've been doing it for 30 years. The real question is, why has it taken so long for the correctional system to replicate what New York City has been able to do and do well? So, what really needs to be, I think, emphasized is if we adequately treat people in the community, often they won't end up in jail. Jail is an opportunity, but it is not the best place to provide addiction treatment. And so I think that is a little bit of what we are talking about in all of the examples that we have failed in a way that we have law enforcement and the correctional system providing a healthcare service and healthcare treatment when in fact it should be in the realm of health. And that's where the resources are as well.
Well, that's great. Well, let me bring Dr. Burke and Dr. McDonald in, from Rhode Island and New York, respectively. And we actually, it's a question I asked. We have some questions that have come from the audience. And Gina Carbaugh, the advocate for Richard Carbaugh's Hope Foundation, asked, how do we go about getting more recovery efforts and recovery treatment options into jails or prisons, with both of you are already doing? But Dr. Burke, recently I had Senator Sheldon Whitehouse discussing some of these issues, and he really gave us a kind of tour de force, if you will, of a lot of different dimensions of what Rhode Island was trying to do, was to create a blanket, it's sort of a foundation of treatment options and respect, but would love to have you share that with our audience, what you've been able to achieve in Rhode Island.
Absolutely. I'd echo everyone's sentiments so far, and we're very proud of the achievements in Rhode Island. I think the program was developed in 2016 in response to the opioid overdose epidemic, where the governor at the time wanted people to get together and say, how can we address overdose deaths? And there's clear evidence that a lot of these individuals that struggle with opiate use disorder find themselves incarcerated in jail or prison. The natural progression of addiction is often to find themselves in jail and prison. And so this is a high yield target to intervene in people's lives, to really try to help provide treatment and support. And so in 2016, Rhode Island created the first statewide comprehensive medication for opiate use disorder treatment program. And it's worked extremely well. We're very proud. The evidence suggests that for every 11 people you treat, one life is saved. And so this really demonstrates how important treatment is. And just to echo, Tracy's comment, that I think while we're very proud of the work that we do in our comprehensive jail and prison unified system, it really points to the need for treatment and access to treatment. And not relying on incarceration to be the one that provide that treatment, but really to support community access.
Dr. McDonald, can you share the New York story with us and what you've seen getting traction in your system? And again, I'm always interested in not only what's happening by way of, being humane, but also how do you help someone on their journey beyond the prison system to kind of come back into opportunities where they're not basically subjected to a vicious cycle of, rotating through the justice system because of an inability to escape the gravity of that drug use disorder?
Thank you. That's a critical question. And yes, so the Rikers Island KEEP program, which is the nation's oldest jail-based opioid treatment program, was actually started by many of the people who pioneered the treatment of methadone in the community in the U.S. And so 40 years ago, people understood that heroin users were being incarcerated in New York City and that we needed to get them treatment to avoid some of these negative consequences that we've heard described here. I think what we really have to grapple with is how decades later, this has not become the norm in correctional settings across our country. And it really speaks to a larger failure of the war on drugs, of an approach in this country that sought to solve this problem by criminalizing it. And I think to your question, it's critical to think about how do we support people in the community after release from jail, but more so, how do we avoid jailing people in the first place? Because jail itself, incarceration itself, is a counterproductive intervention for substance use disorders. The things that are most protective and help people achieve and maintain recovery are the positive things in their lives. They're the jobs, the relationships, the housing in particular is a huge problem in New York City. And periods of incarceration, even short ones, destabilize all of those things. So it really requires us to rethink how we approach the criminalization of substance use disorders. But absolutely, if we're going to incarcerate people with substance use disorders, which we do at a very high rate all around the country, we have to have the standard of care medications available to treat those conditions.
You know, I want to ask all of you know this, and Dr. Burke, I apologize if I butcher this word. I'm not good at medical terms, but buprenorphine, is that right? Buprenorphine? Close enough. And I know that,
yes,
that medical-assisted therapies and treatments are part of the picture. And I want to ask you a political question. You know, we live in D.C. here, but I know that we're also dealing with states and localities, and so I don't even presume that the federal level can, impact all these different levels. I'm just sort of interested, as I understand those that are trying to provide medical assisted support, particularly when overdoses have occurred. What is the political driver that gets in the way of wide provision and prescription of the drugs that will help people live? I don't get it. So what's the block?
This is an outstanding question, and I think highlights what the barrier is to accessing treatment in the community, but also in corrections. You know, you previously asked the question, why is no one else doing this? Why, as Tracy asked, why is no one following the model that Rikers has been put in place for decades? And the truth is stigma. There's no reason that this is not more widespread. About 50% of individuals that have overdose death often have criminal justice exposure. There was a great article that came out looking at Maryland data that showed nearly 50% of people who died from overdose had some criminal justice touch within a year. So politically, philosophically, from a science-based, evidence-based background, if you're looking at who should we be targeting to try to help in the opioid overdose epidemic, it's people who have criminal justice exposure and experience. Why aren't jails and prisons implementing this as some of the model states have? And we consider ourselves a model state in this. And I think it's because people are not wanting to invest in the treatment of people that they feel are not equal, that they feel like need to be punished. And it's overall, I think, just a very harmful public health strategy.
I would ask Dr. Sue and Tracy Gardner as well. You're both on the front line of essentially a human rights-based approach, a civil rights-based approach to thinking about this. I'm always interested in whether I tell people there are ways to pursue differences in public policy earnestly, and then there are these bank shot approaches, accidental alliances, odd bedfellows that may help expand our aperture on understanding. I'd just be interested, Tracy, in your experience, what's been successful at opening the aperture? Maybe it's lawsuits, which I knew. Maybe that's the court system, opens people's minds and you create liability. But I'm just sort of interested in what are from your experiences, what can you share with our audiences that are in their own community struggling with this, that help get, realization about stigma and treatment in, more holistic ways than we have now?
Right, and that's a really great point, because stigma is, in my opinion, a form of oppression. It's the way that we punish people when they're not behaving in a way that we find acceptable. Legal Action Center just, finished a really important report on how people who are perceived to have substance use disorders or who do are treated in our emergency rooms. And we have found that in many cases, the treatment of people who come in, particularly after a non-fatal overdose, violates several important laws, including the Americans with Disability Act, as well as a few others. So not only is it medically unwise, but you're also violating people's rights. And this idea that we could actually address the symptoms of the health emergency that individual is in an emergency room should be a no-brainer. We do it for people who present with asthma, with heart complications. The immediate response should be healthcare. But we have a lot of, there's a lot of antipathy for people who use drugs. And what I would say is when you engage people who use drugs, that in a way that acknowledges that they know what works for them best. No one is born saying they want to grow up to be an injection drug user. So, you know, and using drugs does not eliminate the ability to want to say, this is what would really engage me. So, you know, you talk to Dr. Sue about her patients and the people she's working with, and they are absolutely the primary expertise in how we build these systems that don't alienate them, but actually engage folks well before they end up into the justice system and even after.
Well, let me ask Dr. Sue and Dr. McDonald a quick question, then we've got an audience question. But I want to ask this question, and it's just, I'm on the opinion side of what we do here, so I'm allowed to have opinions. And I guess my opinion is that you know, when it comes to the concept of harm reduction, you know, the debate as I see it out there is this kind of weird one in America where we pretend at some level to be, you know, Puritans, that, you know, people don't drink, they don't smoke, they don't have crises, they don't have behaviors, and that there's this notion that if you talk about harm reduction, some people say, well, then you're giving permission and space for people to deviate from that ideal. And I find it really offensive, you know, that notion, because I just don't find it based in reality. But I imagine that must be one of the arguments you run into a lot. And in my mind, it's like, you know, go look at your family, go look at the people you're related to, go look at the people you like in the community. Everybody has it. It's like, come out, you know, just come out and, you know, look at who people are. So I'm just interested in what do we do from both of your experience to just make reality more embraceable? Does that make sense?
Yes, and I'm just going to jump in here because I know Dr. Sue is going to speak to it. But harm reduction is not unique to the issue of drug use.
Of course.
We use harm reduction. Filters on a cigarette are harm reduction. Seatbelts are harm reduction. For people who are going to do the activity anyway, we have a number of ways to make it safer. And that is fundamentally what harm reduction is about. And it's not about encouraging people to do this behavior. It's about ensuring that they do it safely.
Sure. Thank you. Dr. Sue?
Yeah, I mean, really, it's about humanizing people. It's about meeting people, you know, where they're at, and you know, it's not a revolutionary strategy, right? It's like Tracy said, it's what we do in the clinic. We make sure people are wearing helmets. We make sure people are wearing seatbelts. We make sure people have the equipment that they might need to use to inject or to smoke substances. You know, like you said, we have a very puritanical society here in the U.S. It's a very disingenuous stance in many ways. I write about this in my book, and I go back to sort of, you know, some of our early writings about prisons and jails in the 1800s, and this idea of reformation and absolving of sin, like that's very baked into a lot of our current understandings of substance use. And, you know, so many people, you know, all of us here have used psychoactive substances, you know, to feel better, to achieve sleep, you know, to have pleasure, right? And so these are all very human things. We've lived with intoxicating substances and managed to make them and use them for, you know, thousands of years in all societies and cultures, right? And so I just want to enable people to live and to live with dignity and respect.
Right, and let me final word for the audience to Dr. McDonald. But I have to say, Dr. McDonald, I don't know if you know her, but someone I know who was incarcerated at Rikers and who's come out as a Reverend Vivian Nixon, and I find her to be an incredibly inspiring person who works with those, particularly women coming out of prison who have had all sorts of disorder challenges, mental health challenges. I met her through the Aspen Institute program called Ascend, which tries to kind of look at how do you change these patterns across the way. Now, I know that, and I know Vivian Nixon and admire her so much, but I have to say that until this happened, I did not know about the right. What can we all do to help give you lift I mean, you're sitting with one of the oldest and best and you know, major programs, but I'm just wondering, what do you need to help spread the word a little bit on the practices you're using? You're muted.
Sorry, well, that's a great question. We've tried to spread the word, and you know, I've been lucky to collaborate with all the other panelists here as part of a movement to try to help our colleagues around the country achieve what we've done for many years. I think it's important to point out that this work is not easy. To provide these medications in a complex location like a jail or a prison is difficult, it's costly, and it requires a real societal commitment. I think what we need to understand as a society, though, is when we incarcerate people, it comes with an obligation to provide them with treatment. And so I think we're happy to help, and thank you for today spreading the word and to provide technical assistance to other systems. One challenge which we should mention is that many security people are mostly concerned about diversion of medications in the facilities. And one of the most important messages is that that is an issue that comes up when you implement these programs, but it's a problem that can be managed and can be solved. And it's not in and of itself a reason not to use the medicines that we know save lives.
Right. Well, we have a question for you folks from Don Mathis. Don?
I'm Don Mathis, a certified peer recovery specialist at Voices of Hope in Aberdeen, Maryland, and former case manager for our county's 4 drug courts. My colleagues and I thank the Hill for hosting this important event. My question, what strategies and messages are effective for reducing the stigma that some in law enforcement have against people with substance use disorders?
Terrific question. It's been something we've been talking about. But why don't we start with Justin Burke? Dr. Burke?
I think this is an incredibly important question, and it's a tough question, especially when, to Dr. McDonald's point, correctional officers for years have been working to get buprenorphine and medicine similar out of the jails and prisons, out of diversion efforts. And so to one day say, no, this is medication, you were letting it in droves, causes some confusion and mixed messaging. And I think over time, people recognize when they see the miracle drug of buprenorphine or methadone, what people can do, where they can change their lives from rather than waking up in the morning trying to find something on the street, honestly, to prevent withdrawal, prevent them from getting sick. They can go to focus on their family and focus on their job and focus on having a good quality of life. Things that are still need supports. You know, just because someone's on treatment doesn't mean that all of their social stressors go away. And I think this is an important part of the reentry process. But I think as more people become exposed to individuals that they are surprised have opioid use disorder, and more people who are exposed to the miraculous effects of treatment, I think that is really the big thing, and to talk about it and to share that news.
Right. Thank you. Let me get quick snapshots from the other 3 of you. Dr. Sue?
Yeah, I mean, there's a lot of, I'm actually giving a talk on Friday on stigma and what we can do about it. You know, I think reminding people that this is a standard of care. If you have high cholesterol, I'm giving you a statin. I want to prevent you from having a heart attack. This is a standard of care. And when I went up to Albany County Jail and did technical assistance to help them set up their buprenorphine program, many people quit. And it was like, well, you know, this is modern medicine. So if you don't believe, you know, we're going to educate you about addiction and substance use disorders. And if you don't like it, you don't have to work here. So, you know, I mean, that is, you know, we want to bring people on board, but I mean, I think some people, you know, many people have, you know, a lot of experiences that we need to kind of seek and understand.
So we need to build literacy, honestly, right?
Yeah. And we need to just talk openly about substance use. You know, like you said, we're very puritanical. And so, you know, there's all these campaigns in New York City, for example, that has campaigns that say methadone and buprenorphine saved my life. You know, I use naloxone to save my best friend's life. And they have people's faces, real faces of people who are on these medications who are doing well and thriving.
Thank you. Ross McDonald?
Sure. So I think it's important to explain that medically, substance use disorders always mean that people have compulsive use of substances despite negative consequences. That's the condition. And I think so much of what we've done over the last few decades is try to pile on more negative consequences. And I think people can look back or think about loved ones in their lives who've struggled with this and understand that we're not going to punish our way out of this problem. And that's really how I try to frame it.
Well, thank you. And Tracy Gardner, I'm going to give you the last word, so let's make it great.
Absolutely. I'm confident that will happen eventually, just as all kinds of accepting of a norm, a standard of care, as Dr. Sue put it. Many of us have lived through the HIV epidemic, the early days, and we have known, and it's been demonstrated that syringe services programs, for example, which were very controversial at the beginning, then became very well known as a way to reduce infections and reduce mortality for people who use drugs. So I know that it can happen. We all know it can happen. It requires sustained support and education and technical assistance, but it's simply the right thing to do. And that just needs to be embraced, and I'm confident it will be.
I'm just going to say a little editorial comment before I thank all of you. This was an incredible conversation. The whole program was. And I'll tell you, people that are watching right now, you're already tuned in and you already get a lot of this, and we just appreciate you being willing to listen, to learn, to do this. Go talk to somebody who's not tuned in yet. I mean, I really think that the big issue here is that if you scratch beneath the surface, these challenges are much larger in our society than many folks realize. So I do hope that we'll share the story of Rhode Island and Rikers and, you know, what's going on in various communities around this country that aren't getting the support they need. So I'll just say it there. Go share this with someone else. I normally don't say that with our Hill events, but this is an important one. So Dr. Ross McDonald, Chief Medical Officer of New York City Health and Hospitals Correctional Health Services Division, Dr. Kimberly Sue, Medical Director of the National Harm Reduction Coalition, Dr. Justin Burke, Medical Director for the Rhode Island Department of Corrections. Somehow we talk a lot about Rhode Island on our shows. Tracy Gardner, Senior Vice President of Policy Advocacy at Legal Action Center. Really appreciate you all being with us today. Thank you. That brings us to the end of our program today. A very big thank you to Indivior for its support and to all of you attendees for joining us today for these discussions. If you missed any of the conversations that I just said, we're going to have the video up from the event on our website shortly. Go show it to folks. I'm Steve Clements. Be well.